postoperative mortality in patients undergoing valve replacement surgery. The valvulopathy continues to be an important cause of medical consultations and hospitalization worldwide. The prevention of rheumatic heart disease and the phenomenon of epidemiological transition had allowed mortality from degenerative heart valve disease to be higher in elderly patients. In Cuba, at the end of 2020, the rate of deaths due to non-rheumatic valvulopathies was 2.7 per 100,000 inhabitants. Early detection and grading of the severity of valvular heart disease had improved the criteria for selecting patients who are candidates for surgery. In addition, the advances in surgical techniques and perioperative management have resulted in a higher success rate and lower morbidity and mortality. Cardiac valve surgery requires a specific operative procedure for its performance. The complexities of these procedures are related to the patient's and surgical factors, such as the number of valves to be operating on, the system of previous cardiac surgery, the association with revascularization or thoracic aortic surgery, and the quality of myocardial protection provided during the surgical procedure, among other factors. The present research is motivated by the need of factual information related to this topic that allows to identify the most frequent complications and predictors of postoperative mortality in patients undergoing valve replacement surgery. An observational, analytical, and retrospective study was carried out at the ICCCB in Havana from the 1st of January of 2016 to the 31st of December of 2019. The universe includes 753 patients. This slide shows the criteria used in the selection of the universe. Inclusion criteria include patients of both sexes, over 18 years of age with a diagnosis of any valvulopathy approved as candidate for heart valve surgery, patients with cardiac combined condition, valvulopathy and coronary artery disease, psychiatrist patients with difficulty responding to adequate questioning, patients with a poor acoustic window for echocardiography, and patients with consumptive disease, neoplasms, and acquired immunodeficiency syndromes were excluded. The following variables were included in the study: sociodemographic and pre-surgical variables. The information was obtained from the medical and echocardiography report. The data was obtained in a model elaborated for this purpose that collected the variable of interest. Frequency distribution tables were prepared and statistical methods were applied using HPCC. Summary measures were used for descriptive variable, mean, standard deviation, and percentage according to the type of variable. The research was approved by the scientific board and the ethics committee of the participating institutions. The integrity of the data obtained was guarded. The ethical principles for medical research in humans established in the Declaration of Helsinki were compliant with all the time. The patient age 16 years old or older accounted for 52.2% of the total samples. The male sex, 52.3%, predominated over the female sex. Among the main pathology antecedents of these cases, arterial hypertension, pulmonary hypertension, and diabetes mellitus stood out. 31.2% were reported to be former smokers. Aortic valve replacement, 48.5%, was the most used surgery, followed by mitral valve replacement, 36.7%, and doublet replacement, 14.5%. More than 60% of the patients had filtration values included in category 1 and 2. More than 90% of the cases had left ventricular ejection fractions values above 50%. The table 1 shows variables related to the surgical procedures. The anorexia arrest time was 18 minutes, the extracorporeal circulation time median was 110 minutes, the surgical time was 4 hours, and the anesthesia time was 5 hours. The most frequent complication was electric one. The use of electric shock were necessary in 29.2% of the cases. the predominance of ventricular arrhythmias during the reperfusion first moments are frequent, and these are conditioned by a series of mechanisms such as the duration of the ischemia period, the severity of the metabolic change produced by ischemia, the cytosolic calcium oscillations, the catecholamine flow produced during ischemia, and the speed of reperfusion. Other favorable circumstances could be the hydroelectrolysis alterations, the release of oxygen, free radicals, the ventricular dysfunctions, and the hemodynamic instability. Between the septic complications, the endocarditis was the most frequent, and the main causal microorganism was Staphylococcus aureus. It should be taken into account that perioperative antibiotic prophylaxis is very beneficial in reducing the incidence of infectious complications in patients undergoing cardiac surgery. The mortality was 6.6% of the samples, 50 patients. The complications most related to mortality were the cardiogenic choke, low cardiac output, and sepsis. The use of extracorporeal circulation allows the surgeon to work in a sealed and bloodless field, but can cause varying degrees of myocardial stoning. This is why, when the patient has a pre-existing deterioration of systolic function, it is most likely to present low cardiac output due to a transitory worsening in contractility due to the impact of the pump at the level of the cardiac muscle. Interesting to know the possible associations between the variable collective and mortality. The table 4 shows the patient distribution according to socio-demographic and clinical variables in relation to the patient condition at discharge. Statistically significant differences were observed for age, both in mean values and in patient age 65 years old and older, 34.4% versus 60%. Diabetes mellitus was present in 32% of deceased patients, in contrast to 10.5% of those discharged alive. The glomerular filter rate values were slightly raised in deceased patients. However, the difference between the deceased patients and the live ones was not significant. A similar analysis was performed between the mortality and the variable related to the surgical procedure. The table 5 shows the results of the median values for anoxy-arrestant, extracorporeal circulation, and cervical time, all statistically significant. The variable found were significant in the above analysis related to the mortality were included in a logistic regression analysis to obtain the disparities ratios shown in the table 6. Age greater than or equal to 65 years old must triple the risk of dying. The women were 2.5 times more likely to die before discharge after valve surgery. A glomerular filtration rate below 16 is a predictor of mortality in these patients, almost doubling the risk of occurrence of this adverse event. Diabetes mellitus was a predictor of mortality since patients with this risk factor had a disparity ratio of 4, the highest in our series. Conclusions. Extracorporeal circulation continues to be the technique of choice for valve replacement, together with good myocardial protection and short anoxic arrest, CPV, and cervical times, reduce perioperative mortality and morbidity. Complications in patients operating on for valvular disorder are low, with a predominance of arrhythmias that generally occur due to alterations in the internal environment and acid-base balance. Aging, the presence of comorbidities such as diabetes and impaired renal function predispose to the development of complications that lead to death in this patient in the postoperative period. Surgery, of course, is a safe therapeutic option for patients with valvular apparatus diseases, although it is not free of complications, so adequate preparation and multidisciplinary discussion is necessary in each case. Thank you very much for your attention.
Thank you very much, Dr. Alexander Martin, for that wonderful presentation. I don't know if we have any question with reference to the presentation. In the absence of Question.